So in this area of very well-tolerated treatment, and like we just heard about patients with ALK-positive lung cancer living up to 8 years, we know that we're going to encounter some resistance. Cancer continues to evolve over time and continues to overcome these inhibitions that we're doing with the targeted therapies. So it is inevitable that patients will develop resistance to the target medication. We don't know exactly when. We're learning little by little who are at higher risk for this. But it's important to understand that oligoprogression, that means a few sides of the disease growing when the rest of the disease is under control. It is an opportunity to regain control of the tumors that are growing with local treatment. Okay? So oligoprogression has given us the opportunity to treat those sites that are growing when the patient still remains in the targeted therapy. And why is that important? Well, the quality of life of many of our patients is better when they're in targeted therapy. Taking a pill instead of getting chemotherapy. Also, it provides control for a mutation that we know that you have. It's the best tailored treatment. So treating these sites of disease that are growing here and there allows to keep our patients in the target therapy for longer time before switching to chemotherapy and to the less effective immunotherapy. But there are two important things we need to know about oligoprogression. The first thing I look at is the presence of symptoms. Is this oligoprogression giving symptoms to my patient? Often we see it when there is disease progression in the bone, right? The tumor is growing on the bone. It tends to produce more pain, especially if it's in the back when patients go to bed. Is the disease growing very close to the airway that is causing cough or is causing cough with blood? So the main thing for me is, how is this affecting my patient? And where is the site of the disease progression? We need to understand that we also need to follow the criteria for disease progression. It needs to be more than 30% of the regional size in order for us to say that the cancer is growing to a significant point. The disease sometimes, particularly with immunotherapy, can wax and wane. So when we call it progression, disease progression, it needs to be over the 30% of the regional size or the size to call it. And the second thing is, what resources are available at my institution that will allow me to treat these little spots of disease progression. I'm very fortunate to be in an ivory tower in which I have many resources to treat this, but not all these resources are available all across the United States or outside of the United States. And finally, in number two, we need to make sure, particularly with patients that have an EGFR mutation, that the disease has not transformed to a small cell. And we're going to talk about that. So when we talk about disease growing in certain spots, but being controlled in the rest of the body, two things: symptoms, what can I do for this? What do I have available? And I need to make sure I'm not dealing with a different disease that has transformed. And I'm putting this image here to stop and understand that our patient's health is as delicate as this snowflake. We need to make sure that, or communicate and listen to our patients. A lot of signs of oligoprogression I have identified before the CT scans. My patient tells me that they just have this new abdominal pain. Sometimes that's a capsular dilation from the liver, that they have this back pain that return, that looks and sounds similar that when they have diagnosis of lung cancer. So there is a very fine line to make sure that we don't miss the oligoprogression or it becomes full-on flank progression. So listening to our patients, having a good communication, we allow us to make early diagnosis to control the rest of the disease. And I cannot stress enough that the treatment of oligoprogression or litoprogression needs to happen with a multidisciplinary care team. I wish I could do everything in my patients, that we make scheduling quite easier. But we often have to work with surgeons, radiation oncologists, pulmonologists. We need to talk to interventional radiologists to treat this disease And also, in cases in which you're not sure if the disease has transformed, to talk to your pathologist to evaluate a repeat biopsy.